Right, I think that's it. That's up and running on Facebook now, so we should be good. Right,
Okay.
Thank you so much to everyone for joining our Q&A session today. We've got Dr. Alan Bonder with us from Boston today. Thank you so much for joining us. We love to see you joining us from the US. I think we've got quite a lot of questions that have specifically came in from the US today, which is great as well. Just to say before we get started, our Q&As continue to be as popular as ever, but just remember that we do receive a lot of questions every week. And that they don't take the questions that we ask here don't take the place of a consultation with your own clinicians. We're aiming to provide general medical information and not specific medical advice. Also, please bear in mind, Facebook's a public forum, and for more privacy, you can join us here in the room and click meeting. So I'll keep a wee eye on Facebook for any questions that we've got coming in, but in the meantime, I'll make a start on the questions that we've sent in for this week. I'll just get those ready for us. So we've got a question around a patient who was diagnosed with PBC 3 years ago as AMA positive, along with raised ALP and GGT. Recently also tested positive for SP100 and wanted to understand whether that's a bad thing and whether it's associated with worse disease progression. I wondered as well if it was worth commenting on AMA. We've then got a question about ANA and then the GP2-100. So I thought that might be a good thing to cover as well.
Thank you, Melissa. Again, thanks for having me again. So this is a great question. So the current guidelines of what we usually do, if a patient has an elevated OCFAS and a positive AMA, that's how we diagnose patients with PBC. And based on that, we start on treatment. Right now, there are other antibodies that we know that are present in patients with PBC. So as you mentioned, there is subtype of anti-nuclear antibodies. That's why we call them ANA. Specifically two type, the SP100 and GP210, which are subtypes of ANA antibodies. They are associated with PBC. What it looks like that for the future guidelines, what hopefully will be done in the near future, is same as you do have a positive AMA when an elevated OCFAS, same will go for this new antibodies, right? So if you have a positive ANA, GP2, 10 or SP100, and you have an elevated OCFAS, you will be diagnosed with PBC. So there is now a lot of research looking at prognosis based on your antibody profile. I don't think it's prime time ready yet, but I think what we've known is some people with those antibodies have a specific type of disease they can actually develop. But again, I want to just not go into details, but I would say is right now this is not ready to go, but I think we're looking at the antibody profile to see that can be a prognosis for the different types of disease that the patients with PBCs are getting.
So that could potentially be different in terms of disease progression by the different antibodies.
Or we call it disease phenotype. So there's different types of disease activity. For example, we're seeing a lot of people presenting with just abnormal liver tests, but we also see a lot of people presenting with advanced liver disease issues. They have fluid in their belly, cholestasis, or they have what's called portal hypertension, variceal bleed. So it depends on the profile of the antibodies, the type of disease you will get. But again, this is really now undergoing extensive research, and we will know this in the next couple of months or even years.
Thank you. So the next question is similar. So can you have the GP210 antibody and not have PBC?
Great question. And the answer was yes. There is a lot of people hanging out with positive antibodies. We know that an AMA without the presence of the OCFAS not necessarily will give you a diagnosis, but you are more at risk of developing PBC. And again, 10% of the general population would have some type of positivity in the antibody, in the ANA. That doesn't mean they have the disease. They need to kind of meet the features of the guidelines. You have an elevated OCFAS or you have symptoms, and then actually how we diagnose patients with PBC.
So again, similar for the next question, it's asking about the ANA GP210 positive result, but with normal ALP and GGT, but with raised ALT for years. Does that confirm you have PBC? So again, just slightly different, but along the same lines.
It is very complicated, and I would say the answer to the question is, I would say unknown. So again, just the guidelines say that you have to have 2 out of the next 3. An elevated OCFAS, a positive antibody, either AMA, ANA, the subtypes that we just discussed, or if we don't have any of those 2, a liver biopsy findings of PBC. If you don't have those 2 out of 3, you don't have PBC. You might be an increased risk, and you might develop the PBC, either symptoms of abnormal liver test in the future, and that's how we follow them. when you have an abnormal ALT, that's not very common with patients with PBC. That could be common for other things. So, for example, I've had a lot of people coming with a positive antibody, which they have metabolic fatty liver disease, or they have other types of diseases. So I would say if you have an abnormal ALT, I will look at somewhere different. But yes, I think with a positive antibody, we have to think about you are more an increased risk of developing PBC in the near future.
Great, thank you. We've also had a couple of questions around UDCA. Is UDCA effective for ANA GP210 positive PBC?
Yes, the answer to the question is yes. So the response rates, again, I don't have a lot of data or a lot of kind of research evidence that show that any of those subtypes of ANA will actually act differently than AMA. Mm-hmm. But we know that you have PBC. We know 60 to 70% of the patients will respond properly to UDCA.
And a question around, is TUDCA as effective as UDCA for treatment?
Again, based on the data that we have available, the answer is unknown, but I would say right now the only first-line therapy that we have is UDCA.
Thank you. Patient who was diagnosed in 2013 by a positive AMA and a liver biopsy. Their last few AMA tests are now shown negative. Is that normal, and do they still have PBC?
Good question. Is once you get diagnosed with PBC, I don't think there is any kind of a follow-up about the titers or the presence of the antibodies. Again, it is tricky to say that you lose your antibodies with PBC, but you have histologic findings. Regardless of what happens with the antibodies, I would say that person still has PBC and still need to continue the regular therapy.
Okay, thank you. Patient diagnosed 2012 with positive AMA and biopsy. Ultrasounds are only showing mild coarsening. She can't tolerate urso, and the liver enzymes are not currently elevated. Should they be on one of the other medications? We do have a couple of questions about the new medications as well today, so I think it's considered.
Well, the answer to that question is yes. So they are what's called intolerable to UDCA based on side effects. So yeah, those patients should look into a second-line therapy. I mean, based on the current data, we know that those patients respond well to second-line therapy. And again, I would advise for them to go into a second-line therapy as soon as possible.
Okay, thank you. Patient who was diagnosed 9 years ago, the only monitoring that's been offered is the liver function test every 6 months with their GP, but their liver function tests are currently in the normal range. They've not seen a consultant since or been offered a FibroScan. Is this adequate monitoring for someone with highly positive AMA antibody?
Again, good question. So as I told you, if you look at the guidance, right, if you have a positive AMA and your liver numbers are completely normal, so data shows that 1 out of 5 patients will develop PBC. So if they have normal liver tests, there's two kind of schools of thoughts currently. One is, because at some point you can develop PBC, some physicians will start UDCA because it's pretty a benign therapy. And the other school of thought is you can follow their liver test every once or twice a year until develop even elevation of phos, or by any chance they get a biopsy and it shows features of PBC. As far as the FibroScan, it's hard to justify a test with normal liver tests, but again, I just don't know basically the details of the patient. So there could be more details about, does a patient have diabetes? Does a patient have any other comorbid issues that will actually trigger us to, get another test? So I can't answer that, but if the patient has normal liver tests, I will not go for a FibroScan unless there is something that will trigger me to go for that test.
Great, thank you. We have a patient who has had severe fibrosis, and the most recent FibroScan this year shows no fibrosis with no changes to the lifestyle made, but their ALP is the highest it's ever been. How does that make sense? They're not taking any medication at the moment for PBC.
Again, let me just rephrase that. The patient has no fibrosis on the biopsy, but yes, fibrosis on the FibroScan?
No, 1 year ago, severe fibrosis, and then the most recent FibroScan shows no fibrosis.
And both were done by FibroScan?
Yeah, and they've made no changes to their lifestyle.
They're falsely positive or elevation of the FibroScan. So for example, if the FibroScan is done without the proper fasting, so at least 3 hours of fasting, that can falsely elevate the results. Sometimes when the liver tests are really, really high, that can falsely also elevate the results. I don't know what was the point of one test to the 1 year, and I'll have to look again in detail with that patient. But if right now there is, good normal test and a FibroScan less than 5 to 6, then the risk of that patient on having progressive liver disease is very low.
Thank you. Just while we're talking about FibroScans, we've got a question around how do MRE, MRCP tests compare to FibroScan, and are they worth getting? So just the differences around those and how the monitoring should be done.
I mean, so when you look at kind of like we call it in the medical world sensitivity, specificity, how accurate they are diagnosing or ruling out the disease are very kind of comparable. The only thing is cost. The MR elastography involves an MR, an MR versus, FibroScan elastography is an ultrasound done in the clinics. So we think as FibroScan as kind of like the 6 or the 7 vital signs in a liver clinic. You come in, you get your ultrasound, the stage of fibrosis based on elastography versus just an MRE. You need to send them to a radiology where they have the software. So it's a little bit more kind of like, I would say complicated, but it's a little more collaborative with another department. And again, it's of course more expensive, but the results are not any different. So we use elastography as much as we can as a first tool.
Question around the patient who has ALP has been in the range of 1200 to 1600 at their highest since 2021, and they've been on urso since that. Besides that, all the other numbers have been normal until recently. Bilirubin is now at 6.7, and they did receive a blood transfusion due to hemoglobin dropping below 5, and they now have jaundice. Is anything within that connected to the PBC, do you think?
That sounds like a very advanced PBC, and based on that numbers, that person needs to be evaluated for transplant as soon as possible.
Okay, we'll make sure that gets back to that person who put the question in as well if they're not listening. Patient 34 years old from the United States, haven't seen a hepatologist since 2021. Alkaline phosphatase levels were around 1200 at the time, and that's when they were told they had PBC. Second visit, they were told they weren't so sure then about the diagnosis because the blood tests were then negative for PBC. They've done all types of tests. Liver just detects mild scarring. They also have stage 4 chronic kidney disease and a severe case of anemia. Bilirubin last checked at 6.7. They're jaundice. I think this is actually a very similar question to the one above, and I'm wondering if the person submitted 2 questions. When I got to that point where the bilirubin was the same, 6.7, I'm thinking, I think that's their question is slightly different, and it's asking if all that's related and is there anything they can do to improve. But I think we've already covered that, and I'll make sure that person gets a follow-up call.
I want to say when that bilirubin goes above 2, that disease is really hard to stop, and I think those patients need liver transplant evaluation as soon as possible.
Thank you. A patient who their ALP was starting to come down, but it had shot back up, they were wondering if taking gluten by mistake could affect their ALP, or if there's anything else that can impact ALP aside from the PBC.
I mean, medications and supplements can definitely affect the ALP. So I would advise for people who have PBC, who are taking UDCA and their numbers are not coming down, try not to take any supplements because that can mask the PBC activity. And we physicians won't know if it's one or the other one. So usually I tell my patients stay away from supplements because they have no activity against PBC. There's never been any trial or any data that show that any other supplements out there will actually benefit treating the PBC.
Great, thank you. The patient that we were talking about there was just diagnosed about last month. They've got an appointment for an ultrasound in 2 weeks' time, but they've not been offered a FibroScan or bone density scan should they request those. How often should patients be having FibroScans, bone density scans?
So FibroScans, I do it on presentation, so at the time of diagnosis, and then I usually do them every 1 to 2 years just to look at the progression, because now there's tons of studies looking at FibroScans as one of the major or key kind of components of the disease activity. So we look at the alk-phos, we look at the bilirubin, but now FibroScans are getting in there. So a FibroScan is not getting better, or actually it's getting worse. It's a poor prognostic sign in patients with PBC. So I do it every 1 to 2 years. As far as the bone density, I do it at the time of diagnosis, and based on the results, either they have normal osteopenia or osteoporosis, I do every 2 to 3 years, like repeat bone densities and make sure that they get their bone health assessed as soon as possible.
Great, thank you. Similar, another one around monitoring. We've got a patient who says they're lucky enough to get their bloods checked with their local GP every 3 months. And when they ring to make an appointment, the receptionist will ask what bloods are to be done. She always just says she needs a liver function done, but should she be asking for anything other than that, anything specific?
Again, good question. The clinicians approach PBC every kind of clinic visit differently. So for me, what I do the liver function test, ALP, AST, ALT, bilirubin, and GGT. Mm-hmm. I do a CBC. I do BUN, creatinine, and INR, and I do, for example, vitamin D, which is just to make sure they don't absorb vitamin D. At the time of diagnosis, I do a thyroid function test and bone densities, and then I do an IgM and a lipid profile. I do a cholesterol, LDL, HDL on if they're fasting. And when they come to see me every 6 months, or depends on how the disease activity is, I'll repeat this test without the thyroid, without the bone density every 6 months. Again, that's not universal, so I will let whatever clinicians they're seeing, choose whatever specific test they want to do. But if you get the basics, that's okay.
Yeah, and I think it's been left with the patient to advise when they contact their local surgery what tests they need. But I would say the next opportunity she gets to have a chat with her liver doctor, that she asks, is she asking for the right thing, and is there anything else in addition to be added to that as well? A patient who wasn't responding to Ursula alone, so was put in bezafibrate last year. They're 29 years old. After the new medication that's recently been released and watching some recent of our Q&As, there was mention of other second-line treatments. So we've got UCA, which we've already had. We've got elafibranor, seladelpar, should be given before third line, which was considered as bezafibrate. Should this be changed now new treatments are available, or is it safer to remain on bezafibrate?
That's a great question. Is right now, and I'm going to talk what we do in the US, because what Europe has is completely different. So we don't have available bezafibrate in the United States. So we don't have it unless you go into a clinical trial. So I would say my second line therapy starts with either seladelpar, elafibranor, or obeticholic acid, depending on what is kind of the patient features. If that patient is responding to bezafibrate, meaning her OGFAS is coming down, all of our markers of disease activity are coming down, there is no need to switch them to a different agent. If by any chance those markers are not getting better, then I think they should talk about using something else. The good thing about bezafibrate is affects all the receptors of a specific kind of mechanism, versus seladelpar is only one and elafibranor is only two. So there's never been kind of a head-to-head comparison in clinical trials, and I don't think there will ever be. But I would say just ask the clinician to see if they're not responding, they should look for an add-on therapy or looking for something different. But bezafibrate is as good as the new medications that are approved. So if I had bezafibrate, I would use it also, but unfortunately I don't.
Thank you. Another question about bezafibrate is asking if it can be taken during pregnancy, and if we know if any of the other three drugs, UCA, elafibranor, seladelpar, are safe to be taken alongside Urso to keep ALP down during pregnancy.
This is a great question. The answer is we do not have any trial data in pregnancy. So right now we advised against it because we don't have no safety data. So bezafibrate have been used for years and years. Again, I think this is called a pregnancy class C or class D, which basically the risk benefit needs to be discussed with the patient. But if the patient is pregnant and has not a lot of fibrosis, my best recommendation is to take them off the medication during pregnancy, continue UDCA, and once the pregnancy is over, basically restart. Also, one other kind of important piece of information, during pregnancy, the OGFAS goes up. That's normal during pregnancy because the placenta produces its OGFAS, specifically in the late second and the beginning of their trimester. So even if you go into pregnancy with normal disease activity and your OGFAS starts going up, that doesn't mean that the PBC is back. Could be that this is just elevation of OGFAS related to pregnancy. So, they need to be followed closely. But again, my advice is to be against using any of those new medications until we have safety data in patients who are pregnant.
Great, thank you. We've got a question that's come in live on our Facebook feed. So we've got someone asking, is it possible to get numbness in your feet and fingers from Urso? And can Urso affect thyroid function? Theirs went from 4 to 10 in 6 weeks.
The answer is no. Urso has no major side effects in the neurological system. And again, the thyroid disease is most likely related to the PBC. So the most common extra liver disease that's out there is thyroid issues. Thyroid issues can happen between 30-40% of patients with PBC, and it's normal. So usually what we do, we check the thyroid function test, and we do a kind of complete workup in the thyroid testing and then send them to the endocrinologist to actually find out what's going on. But it is very common to have thyroid disease in patients with PBC.
Thank you. We have a patient who is going to Mexico in the summer, and they've got concern about the long flight. They haven't been diagnosed with varices, but not had the camera test. They're a bit concerned about, so they've been putting it off, but she's been told that she's low risk. They have PBC AIH with stage 4 cirrhosis, and she's worried about the long flight could cause issues.
Again, it's hard to comment on just based that information. So I would say with cirrhosis abnormal liver test, there is no really increased risk of going a long flight or not. I mean, I would say the biggest risk of being in a long flight is, can they have clots in the legs, clot in the lungs? But again, those PBC and AIH with cirrhosis are an increased risk. If they're completely stable, the answer is no. But I don't know the details, so I cannot comment to that question.
Yeah, no, we appreciate that. And we always add that caveat when we're given answers here, is that we are taking a very general approach to the answer and we don't have the patient's full medical history. What I would say is, if we're answering the question and you feel that we've not answered it in enough detail for you, we can look at doing a helpline call, which would make it a bit more personalised for the person. So please reach out to us if that's the case. We do try and take all the questions that we get in and generalise them a bit more. So hopefully then it gives more information for everyone. But I appreciate that can be a bit difficult if there are some specifics as well. So we have normal LFTs, but occasionally ALT goes up when they have a flare of UCTD, undifferentiated connective tissue disorder. ALP never rises, nor does GGT or bilirubin or any of the other markers, but they did have jaundice last year with no warning but recovered well. They said it was a drug-induced liver injury, and they're asking if this could be Sjogren's attacking their liver.
Again, tough question with a kind of little clinical information that I'm getting, but I've seen cases with connective tissue disorder when they're flaring, the liver test flare with them. I've seen people with scleroderma flaring their scleroderma, and basically their liver test flaring with them. As you get the disease under control, the liver numbers get under control. And also it could be drug induced, as they mentioned, right? So there's a bunch of new biologics, new type of therapies as patients take. So that could be also drug induced or some type of other autoimmune thing. So again, I cannot answer the question with certainty, but that's all good possibilities.
Okay, thank you. Notice we've got someone who's joined us in the room here as well. Any questions, please just let us know in the chat as well. So, right, so diagnosed August 2024 with stage 1 PBC through a liver biopsy, 47 years old, liver enzymes were elevated 2 years before diagnosis, and also had elevated lipase level 127, upper level of normal, consistently for the past 2 years. They're AMA negative, GP210 negative, and SP100 negative. Started taking Urso in August, and all the numbers have come back into the normal range with the exception of the ALP, which is 125. The MRI showed a normal pancreas and have upper and lower GI without any abnormalities. Any thought in the direction that they should move in to figure out whether the issues with their pancreas? They've also had their gallbladder removed 19 years ago. I appreciate that, it's a very specific question. Is there any way we could package that to make it slightly more easy to respond to, or is that something we're not?
I think it's okay. I think, we are so focused on getting it to normal. There's really, from the brief clinical history that I got, there's a lot of really kind of good kind of clinical hints. We know we don't have a lot of fibrosis. The alk-phos is almost ready to normal, right? So we consider a high normal like 105. This is 125. So I think we do consider this patient, based on the current data, a responder to therapy. So I would say, based on the things that I've told from the PBC perspective, this patient is in good kind of like term, and I would say good prognosis from a PBC perspective. I would not look for anything different. I think, as long as you take your DCA, this patient will do well.
Brilliant, thank you. Patient who's had 9 vertebral fractures randomly over the last 3 years, which they're told is PBC related. All numbers are in the normal range. DEXA showed spine at -1.1 in the beginning. They're told now that the DEXA can't get a read now because of the damage, but their calcium, magnesium are all in the normal range. Do you think it's related?
Again, a tough question to answer. I would say based on that T-score and based on that calcium magnesium, I just think that the patient maybe has the beginning of osteopenia. But again, besides that, I cannot say anything. I'll have to look at the numbers specifically. So I would say yes is related to PBC, but now vitamin D and calcium will be the most advisable therapy that I would use. And again, if the patient smokes, stop smoking, and then do some kind of weight-bearing exercise to try to increase kind of the bone strength. But besides that, I will not encourage anything else.
Thank you. We've had some general questions around diet for PBC, and I know we've touched on, there was mentions of supplements earlier. We often get quite a lot of questions about supplements as well. Do you have any general advice around diet?
No. They can eat whatever they want. There is no kind of really diet restrictions at all. Actually, the opposite, you know? So
I'm going to ask Professor Jones to listen to your session, Dr. Bonda, because I never get a yes or a no answer from Professor Jones. We get through about 3 questions if we're lucky in a whole session, whereas I sent you a list of 5 pages of questions because I knew we would be getting through them tonight. So that's brilliant. Thank you. We have, interestingly, a question that's just come in on our Facebook page, but I'm pretty sure it's actually the next question I was going to ask from the list that we've got here as well. So just give me 2 seconds.
Yeah, take your time.
So we've got a patient who's been prescribed ezetimibe for high cholesterol, as atorvastatin seems to coincide with elevated enzymes when they got the diagnosis. Consultant seems to think it was coincidental. However, GP decided to put them on, I don't know if I'm pronouncing that right,
ezetimibe. Yeah.
Is that considered to be okay with PBC to take that one?
Yes. And actually, as you remember, there's some person who asked me what are the tests that I do. Some patients when they have a new diagnosis of PBC, they can have the elevation of their fasting lipids because that's how we absorb the lipids. So when we don't have a kind of a functional bile acid pool and we can't absorb the lipids properly, the lipids in the blood will be elevated. And as you treat the PBC disease, you see how the cholesterol comes down nicely. But unfortunately, on top of that, we have really kind of bad, kind of lifestyle, right? So there's some people who have not only PBC, but they have diabetes, high blood pressure, obesity. In those patients, of course, on top of the PBC, the lifestyle could be a major factor kind of elevating those numbers. And finally, we have also the genetic, part of things. Unfortunately, some of us will have really poor genes that will actually get us really elevation of the cholesterol. So based on this, there's different approaches. Usually we can treat the PBC and see what happens. But you have the genetic predisposition and you have the other conditions. It is safe and it's okay to use atorvastatin or the statins or the other medications to get their cholesterol under control. And I would encourage them to actually get it under control because if you don't, then could be a second hit to the liver with all these conditions causing, metabolic, problems to the liver and causing what's used to call fatty liver. And also on top of PBC, you have a second hit. So it is safe, it is okay to use, and I advise to them if they need them to be on them.
Okay, thank you. We have a patient who had medication-induced liver injury last July after being started on sulfasalazine, whereby I had to be admitted to hospital for 8 days. I was told that they would be sent for a FibroScan, which they've not had yet, and on a recent inquiry we're told they're not scheduled for it anytime soon. They've had PBC since 2021 and they've never had a FibroScan. Should they be concerned about that?
I would wait until the liver numbers from the drug-induced liver injury are better because, again, if you send that person to get a FibroScan right now, that FibroScan is going to be falsely elevated because when there's a lot of inflammation, remember, FibroScan or elastography measures liver stiffness. And when you have a very inflamed liver, for example, in that case of drug-induced liver injury, that FibroScan will be high. And then we can basically falsely give him a diagnosis of cirrhosis or advanced fibrosis based on that. So I'll wait until the numbers are back to normal, and then we can just reassess to see that's the right time for a FibroScan.
So that makes sense. So it wouldn't have been useful to have it while they were in for their liver. Thank you. Patient with microcystic anemia, ruled out celiac and any vitamin or mineral deficiency, but they're feeling terrible. Can PBC cause this?
The answer is no. PBC does not cause any kind of blood counts abnormalities. It is associated with celiac disease, which is the most common iron deficiency anemia cause out there. So I would say if there is no celiac disease, the reason is something else, besides PBC.
Question around new in research for fatigue. Are we aware of anything new that's going on in terms of research for fatigue? It's the most difficult symptom that the patient has to manage since they were diagnosed.
That is so true. I would say that's the symptom that we have a lot of difficulty treating. So if you look back the data going back the last 5-6 years with the new medication, unfortunately, the only one has shown some really promising results is exercise. And you're going to say, wow, exercise when you're that fatigued. Yes, moving is the only thing that really helps. Although I would say there are two medications that in trials have shown some improvement in fatigue. One is the elafibranor. Again, the data is not very striking, not very convincing, but there is a little bit of data. And if you look back, it's called a NOX inhibitor. It's called cetanaloxib. It's another medication is coming out in the pipeline that in the phase 2 trial shows some improvement in fatigue in patients who had a lot of advanced fibrosis. Again, I would say currently 2025, March of 2025, I don't have a medication that will improve fatigue, but we are seeing more of the trials, more of the data showing some slight improvement in the fatigue. And hopefully we will have something as we have for the itching for the fatigue in the near future.
When you mentioned exercise there, we had physiotherapists at our patient conference last year, and they spoke about a trial that they're working on around an exercise program that's specifically developed for the individual patient, because we understand that patients will be able to do different amounts. And if anyone's interested in finding a bit more about that, we've got some information on our YouTube channel about that, the presentations that the physio did for us at the conference. And it was really popular at the conference and for people watching afterwards. So there's some more information on our YouTube channel about that as well. This is something that comes up quite regularly as well. We've got someone asking about weight gain when they've started on Urso and then struggling for their weight. Do you want to just talk to us a wee bit about that?
I mean, that's a tough one. If you look at all the side effects, if you want to online and you look UDCA side effects, yes, weight gain could be one of them. I think, unfortunately, is not very common. And two, we have to exclude other things. And again, thyroid disease is the biggest thing that comes up. Hypothyroidism, low thyroid will be the biggest one. So we need to make sure that we test the thyroid, test for other things. And then before we say this is a side effect of the UDCA. But it is being reported, but it's not a common complication or side effect from the medication.
We've got someone asking about, is tingling on the scalp and forehead a symptom of PBC?
I would say no, but again, is that like tingling more likely related to itching, or is
That's exactly what I thought. Yeah.
So I would say tingling. So neurological manifestations of PBC are very, very unusual. But if you're actually saying itching is more common, then yes.
Mm-hmm. Yeah, because I was thinking that if it's mainly, I remember when I had release of itching, my scalp was itchy, so there was sensation in my scalp. So,
right.
So yeah. Patient currently taking 30 milligrams duloxetine daily to manage widespread fibromyalgia and PBC joint and muscle pain. They're not a candidate for surgery for a defect they've got in their femoral condyle, which they've had for 3 to 4 months. They've been getting cortisone injections. They're just a bit concerned about taking duloxetine long term. Is there any concern about that with their PBC?
No.
See, that's the answer you want. Right. If a patient also has a fatty liver, does the Urso also help with that? And then there's a couple of following questions around intermittent fasting or eating smaller meals every few hours and around protein intake as well. Should we be keeping an eye on our protein intake and making sure we get a certain amount? Or any advice you can give around that?
So UDCA does not help with the fatty liver at all. So it helps with PBC, but not fatty liver. Fatty liver, it is a lifestyle therapy, right? Exercise, weight loss, diet. That's how you treat fatty liver. And again, there's new medications for fatty liver, which I'm not going to go into detail for that. So the diet thing, again, I have no really yes or no or nothing against the diet. So if you do have a fatty liver, yeah, if intermittent fasting helps you lose weight, do it. If it doesn't help you, don't do it.
Mhm.
As far as the other things, I would say the same thing. But again, talking PBC strictly specific, there is not diet or not anything or supplements that will help PBC at all. So I usually tell patients that, if it makes them happy, you can do it. If it doesn't make you happy, it doesn't help, they can stop.
A similar type question, but it's more around gut health. So, patient who's read that the immune system is very tied up with gut health, and what is your opinion about probiotics?
Again, so March of 2025, I don't have any data to show that probiotics or any gut health will actually help or make PBC worse. So that's my answer to that question, Mo.
Oh, that's fair enough. I'm just checking. We have got it's worth giving a shout out as well. We've got people from all over the world joining us today live on Facebook. We've got Canada, Mexico, England, Iraq, which is just amazing to think that that's the kind of spread we're getting for our Q&As. So that's brilliant. Just let me see. We have got another couple of questions that have come in live, so I'll have a wee look at those as well. A patient who's had PBC for 19 years and have been within normal range for the past 4 years on Urzo and bezafibrate. Early last year also developed PMR, no longer seeing consultant or having regular blood tests. Can medication for PMR, prednisone, affect PBC? Would it be a good idea to request liver function tests while taking that?
Good question. And the answer is PMR and PBC, they're completely true unrelated, right? They're autoimmune things, but they're not related at all. And PMR needs prednisone. Again, that does not affect the PBC. It can cause at some point fatty liver. So my advice was to check the liver test periodically, and then they're normal, then they're normal. But there's nothing wrong taking prednisone for other diseases if you have PBC.
Just having a wee look at the. There's actually someone who's joined late is asking about any tips on fatigue. So we have discussed fatigue a wee bit earlier in the session. If you want to have a wee look once I've uploaded it to YouTube, they're also asking about the diagnosis criteria around AMA, high enzymes and biopsy. So we've chatted about that earlier as well, which is great. So that will be uploaded. I'll upload our video this evening, so that'll be available on YouTube later. Same about thoughts on FibroScan. So actually we have covered quite a lot of that. You'll be able to see that in our video once we upload it, or you'll be able to watch it back on Facebook once we're finished as well. Question around how do we get to have a holistic approach to the whole gastrointestinal system while dealing with PBC and AIH? They do have issues with their gut and pancreas, but never get attention to those except the liver.
I mean, I would say there are different gastrointestinal diseases that accompany the liver side of things, right? So when we're talking about PBC, you can actually have a lot of patients with celiac disease. So they have bloating, anemia, could be celiac disease. With autoimmune hepatitis, then sometimes you can have what's called inflammatory bowel disease going with the AIH. So Crohn's disease, ulcerative colitis, non-specific inflammatory bowel disease can go together. And again, some patients with PBC can have scleroderma. They can have what's called motility complications. That means the way that the intestines move around. So again, it depends what the disease is, and it depends what we're looking for. So I think from an holistic point of things is, based on the disease, there are certain kind of clinical profiles that we actually follow to make sure they're not really what the patient is experiencing. And if a patient really has no major gastrointestinal symptoms, besides excluding them by blood test, there's nothing else to be done.
Great, thank you. Patient who's had a biopsy in September showing fibrosis, but significant duct loss. Last week ALP was 631, GDT 997, bilirubin 555. They've had recurrent PBC for 4 years post-transplant, currently on Ursa and Oka, and waiting to get started on elafibranor once it's available in Scotland. Anything else that could be done whilst they wait for that? They've got slight jaundice in their eyes and suffering from itch, fatigue, joint pain and brain fog.
Again, that's severe disease activity, and they've had a transplant. They have to make sure there is no post-transplant complication. So before saying this is recurrent PBC, so recurrent PBC after transplant can happen. It depends on the time after transplant, but I've never seen it so soon. We usually see it after 3 to 6 months after the patients get transplant. But again, that person after transplant should go and look at the transplant doctor, make sure there's nothing else happening.
Yeah, it's 4 years ago they had their transplant. They've had, yeah. It's not, sorry, it's longer than that since they've had your transplant, but they've had your current PBC for 4 years.
Yeah, again, there's a lot of different answers that I can give based on the just numbers. So I would say jaundice in someone who's distant, and you need to go see the liver doctor as soon as possible.
Patient who's saying they've never had the itch and they've not eaten meat for 28 years, do we think there could be a relationship by avoiding meat?
Absolutely.
Patient who can't get their liver enzymes lowered on urso. There's no further comment on that, but I'm suggesting that we have a listen back into the session from earlier where we talked about the other second line therapies and the new medications that are available as well. We've got a patient who newly diagnosed here, fatigue and joint pain, asking about any potential treatments for that and is it directly related to PBC. First of all, welcome to our session. To think that newly diagnosed, you found the foundation, you've found us on here, and you're here been able to ask a question to Dr. Bonder is great. So newly diagnosed patient, they're saying it's making them miserable, their fatigue and their joint pain. What would be the best thing to suggest for that?
We talked briefly a little bit about fatigue. I think again, with the new diagnosis, I would exclude other things that can cause fatigue. So again, thyroid, celiac disease and all that stuff. And after they ruled out, then think about fatigue related to PBC. And as far as joint aches and joint pains, again, PBC is an autoimmune condition, and you are at risk of developing another autoimmune condition, rheumatoid arthritis or lupus or stuff like that. So I would just advise to your doctors to make sure you get tested for these diseases and make sure that's not the case, and then get the right treatment for that. So that would be my first advice, or the quickest advice to do.
Great, thank you. You're mentioning brain fog as well. I'm just catching up on the other additional comments that have been put in there. Quite an active session on Facebook today, which is great as well. We're getting lots of interaction. I'm just going to go back to our, there's no other live questions just now, so if anyone has anything else, please just let me know. I'm going to just pop back to our document that we had. We touched on transplant there, and I think this is a potentially difficult one to answer, but there's a question around, is there an upper age limit for transplant? I think that very, very much depends on the health of the patient, doesn't it?
Correct. I mean, the transplant process, and again, you're in the UK, I'm in the US, it's a very thorough process that involves a lot of people, a lot of physicians, a lot of kind of like social workers, mental health providers. Yeah. So it's a very thorough evaluation. And once you meet all those things, then we decided to put you on the list. And then based on how sick those persons are, then get or not get a priority to get a liver. So that's how usually it works. I will say that's not that simple, but that's actually kind of like we can make it with how we can say it in a couple of words. Yeah, and I know certainly from in Scotland the assessment is a week that the patient goes in for us. It is very thorough. Lots of opportunities for you to get lots of tests done, but also for you to ask lots of questions and all that as well. And there's accommodation made for your family to come in as well, so that they're all part of the conversation as well. So it is a very thorough process. So we've got a patient who's been on elafibranor for 6 weeks along with urso, and they've started to get some heartburn and diarrhea and struggling to go to work when they're out and about, they're not near a toilet. Any recommendations to help with those side effects? And is that a recognised side effect with elafibranor? They were on OCA before, but it wasn't working. I think the heartburn is not related to elafibranor. The diarrhea definitely is a side effect that's being reported in the kind of side effect profile. So abdominal pain, crampy abdominal pain, diarrhea, the common one. So, talk to the physician. What I usually advise is sometimes get a little bit of Imodium, which is an antidiarrheal agent, and then until you figure it out that there's nothing else happening, like no infectious process or nothing else, it's okay to take it, but it will go away as you get used to the medication. It should be mild and really has no really long-term complications.
It's good that we're starting to see questions come in about the new medications, because it's a good sign that these are making it out to the patient. So that's great to hear. Question about, can Urzo cause bladder issues?
No. The answer to the question is no.
Great. And is there a link between PBC and hemochromatosis? I have
No.
2 blood relatives, father and son, with the latter.
The answer is no.
No. Great. That's us back up to date with our questions in the live. So just going to go back to our document here and just see if there's any. I think we've got a couple just left to ask within our main document as well. Patient asking about why does, when they have PBC, they get bloated stomachs. They look 4 months pregnant and they don't have ascites.
You froze for the last part of the question. Can you repeat that for me, Mo?
Yeah, so patient who's asking about stomachs getting bloated. They look 4 months pregnant, but they don't have ascites. They just have quite severe bloating.
Again, for me, it's hard to say, someone with bloating and distension, ascites is fluid in the belly, the first thing, or, complications of the liver disease. So I think what asked them to go look for their GP or their hepatologist or gastroenterologist to be assessed right away.
Okay. Sleep issues is something that comes up quite regularly within some of our sessions that we have. Do you want to talk a wee bit about that? Sleep issues
Sure.
for patients with PBC.
I would say there are sleep disturbances. One is related to itching, which is what we commonly see. Patients who get PBC who are severely itchy. Itchiness, unfortunately, was worse at night. So those patients really are not able to sleep. That's one. But then there's now more data coming out about sleep disturbances related to PBC in people who don't have itching. We know they're more prevalent in patients with PBC. We have no idea why is that happening, but again, hopefully new studies will show why. But again, sometimes depression, brain fog, you name it, but we don't have a really good explanation why. So it is actually a good idea to send them sometimes sleep studies or sending them for rule out other things, and then go from there. But unfortunately, it is prevalent, and we have no really good either explanation or good therapy for it.
Okay. A live question that we've got coming in is around what you were talking earlier about hypothyroid. So in the case of PBC and thyroid, what is the treatment? And how do you know if it's the PBC or if it's a separate disease?
They are related. It's not that the PBC affecting the thyroid is just another autoimmune. I think, think about it as the genes that affect PBC are sometimes the same ones that affect other organs, specifically the thyroid. So the treatment doesn't change if you have hypothyroidism. It's still UDCA, but again, if you need to be on thyroid replacement therapy, that should be okay. That's how we treat the hypothyroidism.
Great, thank you. Patient asking about the best time to take Urzo, and that is something that does come up quite often in our sessions as well. But in addition to that, they're taking Urzo and Oca. So they're just wondering, is it a best time to take it? Can they be taken together? What's the best approach?
You will hear different answers from a lot of us. So my personal opinion is convenience, right? Because it's a 3 times a day, I think that decreases compliance. So I usually tell my patients to take it once a day if they can, if they have no side effects. So as long as they take it, I don't mind if it's with meals or without them, as long as you take them. So again, you will get different responses from different of us. But personally, doing PBC for all these years, that has helped me significantly and increase compliance with my patients. And about the OCA is, again, same thing, So as long as you take it, it doesn't matter. Just want to make sure that you're in the right dose, taking the right time of, the right dose of medications on a daily basis, so you're not missing any doses.
Great, thank you. So we have done an amazing job of getting through our list of questions that we have already sent in, which is brilliant because we've had a backlog for a few weeks because we've had Professor Jones on, so I need to say no more. So, so that's brilliant. We're also up to date with the questions that we've got in live at the moment, but there's just something I thought would be good. We've got 10 minutes left, so just maybe even just for the last 5 minutes, just to have a wee chat about tips for patients getting the most out of their consultations with their clinicians. So we've had some questions around what monitoring should be done, what tests they should be asking for. But we know that often patients, it's limited time for both of us, it's limited time for you guys, it's limited time for us. What's the best that we can do to make sure that we're getting the best out of that time that we have with you that we can?
So, again, as I told you before, Mo, is different clinicians do different things, kind of the standard things that we would recommend, right? Is liver function test is kind of like the biggest and more important things that we need to do. OGFAS, AST, ALT, and bilirubin are kind of the big ones. If we get those, we can get, I would say, most of the information that we need. Unfortunately, I think there are other things that go with PBC. So, for example, I look at the blood counts, make sure they are not iron deficient. I look at the kidney function, look at the clotting factors with their coagulation studies. I look at the thyroidase, I look at the bone densities, vitamin D, and I do a fiber scans every time they come to see me. That way I get a really kind of complete workup, and I know that I'm doing everything actually to optimize their PBC perspective. Again, different clinicians have different amount of time they can spend with patients, and also that also changes what amount of tests they want to do. Some people have more time, some people have less time. Unfortunately for me, I have the time to also kind of throw at them kind of questionnaires about quality of life. I ask about itching, I ask about the fatigue, I ask about the abdominal pain, I ask about supplements. So to me, that's kind of like the way that I can assess really a good complete history and kind of have a really good plan for the next couple of months. The other piece of information that's kind of important is when we want to start one of those new medications, it's so important to understand that they are new, that we have a lot of kind of data for the last 2 years, but we don't know the same as we know with like UDCA. So UDCA, we have 30 years of data. We know that it works. We know that it's pretty safe. And same with the new medications. But again, we don't know what's going to happen 5-6 years from now. So those patients I really monitor a little bit more closely. For the first year, I see them every 2 to 3 months. I make sure that I do more blood tests. I make sure that I ask them about, for example, some patient brought the yellow fever and kind of diarrhea. I bring this up. And finally is symptom-based therapies, right? So I think also we touch base a little bit about, fatigue and pruritus. I do spend a good amount of time in the clinics talking about the symptoms because I think there are really a lot of burden on patients about them. And then again, we don't sometimes have a lot of time to discuss the therapies available or how are we going to get the quality of improved. So again, this is what I do in my clinics. This is how I spend most of the times with patients with PBC. And that's side of what I would recommend doing this. And I'd say one more thing. I think you mentioned a little bit about compliance. We talk about drug medication compliances. UDCA is easy to take, but there are side effects. So we talk about them. The new medications are easy to take, but there are side effects, and we talk about them. And then we talk about compliance. We want to make sure that the physician, sometimes we call them non-responders, but we know the patients are not taking the drugs correctly. So I think things that come up that, clinics will pick up, and then we'll basically make, life for patients and for us a little bit easier. That'll be my kind of like 3-4 cents of the things that we've discussed today.
I love that. And just from the other side of that, as the foundation, we encourage patients to be ready for that as well. So we have a document that they can download to prepare for their appointment. So to make sure that they're coming along, they've thought about any questions they might want to ask. I certainly know myself, if I don't write them down, there's every chance I'll forget them when I'm in to see you. So it's important that they do a wee bit of prep as well and bring along the medications that they're currently on and anything else around that. And we do encourage people to think about the quality of life symptoms and make sure that they're taking the opportunity to discuss that with their doctor if there's been any changes to that. And we do have some resources that are available on our website for anyone. Now, before I let you go, I've had one question come in, which I think is in Spanish. I am going to copy it into the chat here, Doctor, and if you could answer it for us before we finish, that would be amazing. So give me 2 ticks and I'm going to copy it over into the...
And one more thing while you post the question is, you guys have developed this really great app, which has a really nice checklist. So when I've seen patients coming with that checklist talking to me, that really has helped me significantly. So I'll encourage everyone out there to download it. They have the guidelines in patient language. They have everything you need to ask your physicians about it. So I think you should take advantage of this, which is great work from Mo and everyone in the foundation.
Thank you for that. We're also working on updating our app as well, so we hope that's going to have a bit of a fresh look and additional functionality in the near future as well. So I'll let you read out the question and then do an answer for that, if that's okay.
Yeah, so this is a person whose mom's died of cholangiocarcinoma and now has PBC, and then they have two male two sons. So one is there is no really kind of correlation between cholangio and PBC. So there is really no, unless they have cirrhosis, but there is usually another autoimmune thing that is more associated with the cholangio, but not PBC. And there's a genetics part of PBC. PBC really goes with female gender. So it's not common to go down with males. So usually I don't really encourage them to get tested. But if you do have female, like, you have daughters or you have, female, siblings, then I'll encourage them to get tested because there's more genetic predisposition for them.
The next part of the question is from the same person.
The combination of urso, bezafibrate, is there a current therapy? Is there any data or affecting bezafibrate in the long run? And the answer is no. So bezafibrate has been used for more than 30 to 40 years for elevation of some type of cholesterol, and there's never been shown any kind of really long-term damage to anything. So again, this is safe. There are side effects of bezafibrate, but it's a safe medication, and just we need to monitor as we monitor any other medication.
That's great. Thank you so much. That's us fully up to date with all our questions that have come in live, including those last two that you did for us there. So thank you for that. And again, thank you so much for your time. We really appreciate it. We are hoping that the next time you visit us within the next couple of months, it will be a Spanish special that we'll do, and I'll be in touch with you to do that again. We have our previous Spanish special, which you hosted for us, is up on our YouTube channel. So if anyone wanted to have a look at that, it's available up there. Any questions for future sessions, please send them in via the link on our website. There's a contact us option and we'll collect the questions for the next one. Thank you so much for your time, and I look forward to seeing you again soon.
Thank you, Mo, and again, thanks everyone, and then hope everyone's having a good time.
Thank you. Take care. Bye.